Morning, ladies and gentlemen. I warmly welcome you to the second day of the annual academic sessions organized by the Sri Lanka College of Pulmonologists. Today, uh, today we are kick-starting with Symposium 8, and the theme and discussion today is critical care and ventilation. The chairpersons for today's symposium will be Dr. Duminda Yasaratna, consultant respiratory physician, Department of Medicine, University of Peradeniya, and also Dr. Haritha Dharmakirti, consultant anesthetist. Dear sir, the floor is yours to chair.
Right. Good morning, everybody. We are here to conduct another very important symposium on few topics, very few important topics on critical care and ventilation. Um, uh, I think there are four eminent speakers will be delivering their presentations. Two from Sri Lanka and one from Ireland and another one from Spain. So both those is the speakers will not be physically present, and they will give you a recorded videos. So therefore, I think we will keep the questions to the end because that will be easy for us to manipulate. So we will start then. Our first speaker is Dr. Damit Rodrigo, one of my good friend, consultant respiratory physician from District General Hospital Hambantota. He is going to talk about evaluating the acutely hypoxemic patient. Over to you, Dr. Damit.
Thank you very much, and good morning to you all, and thank you, Chairperson sir, for that introduction. Uh, so, the topic that I've been given is evaluating the acutely hypoxic patient. So we'll start with a few cases rather. So you pick up a 82-year-old male, a heavy smoker, who has severe COPD in the morning, who presents with increased sputum production, cough, and worsening dyspnea. The physical exam reveals audible wheezes from a distance and bronchi throughout the chest on auscultation. His vital signs include high temperature, blood pressure of 155 by 90, heart rate of 110, respiratory rate of 28 breaths per minute, and stats of 86% on room air. He was started on nebulized salbutamol and prednisolone. The question is, what is the best oxygen delivery method for this patient? So I've given some options for you to select. The second case, a 50-year-old man is brought to the ER after sustaining a gunshot injury. He has past medical history of type 2 diabetes, coronary artery disease, tobacco smoking, and COPD. He undergoes exploratory laparotomy, during which he receives 5 liters of normal saline during the surgery. Soon after extubation, he develops acute respiratory distress. He's tachycardic. Lung auscultation reveals bibasal crackles. ABG on room air reveals PO2 of 59, pH of 7.47, PO2 of 36, and bicarb of 21. Importantly, his arterial blood gas does not improve with the administration of 100% oxygen. Question is, what is the most likely cause for the respiratory distress? Again, I have given you a few options for you to select. Right. So with these two case scenarios, the questions that would arise from these scenarios, or similar scenarios like this, are: how would you classify a patient's respiratory distress? Or what form of respiratory support should he receive? Or how do you set about to make this decision? In other words, identify the type of respiratory failure and understand which patient will benefit from which form of respiratory support. So with that having said that, we'll move on to the proper part of the lecture. How would you evaluate an acutely hypoxic patient? Right. So first of all, what is hypoxia? So from our medical student days, we have learned the definition. So hypoxia is a state in which oxygen is not available in sufficient amount at the tissue level to maintain adequate homeostasis. So the deficit is at the tissue level. This results from inadequate oxygen delivery to tissues, either due to low blood supply or low oxygen content in the blood, which we call hypoxemia. So hypoxemia is in fact one of the causes of hypoxia, among few other causes. So when should hypoxia be suspected? In the acute setting, in the emergency, if any patient presents with anxiety, confusion, or restlessness, you have to suspect hypoxia. because if your patient is anxious or confused or restless in the acute setting, these signs may precede the vital signs that would appear later. But the hallmark of hypoxia is low oxygen sats or saturation. So in a normal individual, if your SATs, if the patient's SATs goes below 90%, or in case of a chronic lung disease like COPD, if it is less than 88%, then you have to suspect hypoxia. Lactic acidosis will develop later in response to the anaerobic metabolism, and which will appear in a blood gas. So why do our patients get hypoxia? For you to know this, you have to have an understanding about the oxygen delivery method, oxygen delivery mechanism to the tissues. At any point, if this mechanism gets interrupted, your patient can get hypoxic. So either at ventilation, perfusion, or at diffusion, then your patient will get hypoxic. So we say there are 5 cardinal causes for hypoxia. Number 1 being the low inspired oxygen, that is reduced oxygen content in the blood, like what happens in high altitude due to reduced barometric pressures. Hypoventilation or reduced minute ventilation due to airway obstruction, respiratory causes like airway obstruction, or central nervous system depression causing reduced respiratory drive, or neuromuscular causes. Then ventilation perfusion mismatch, or commonly known as VQ mismatch, which is the commonest cause of hypoxia in the acute setting in ICUs. Then right to left shunt, or shunting of blood from right to left. This can be the anatomic, like in the case of ASDs, VSDs, PDAs, or patent forma novalis, or can be physiologic even. Finally, impaired diffusion of oxygen, or a diffusion defect, like in the case of interstitial lung disease, for example. Right. So, what is acute respiratory failure then? So there are these are these things that we already know. You already know. So there are 2 types: hypoxemic or type 1 respiratory failure, and hypercapnic or the type 2 respiratory failure. Hypoxemic or type 1 respiratory failure, the problem is in oxygenation, and it is defined as PO2 of less than 60 millimeters of mercury, and SATs going less than 90%. Hypercapnic or type 2 respiratory failure, the problem is in ventilation, and is defined as PaCO2 of over 45 millimeters of mercury, plus accompanying respiratory acidosis of pH of less than 7.35. So hypoxemic respiratory failure, as I've told you, PO2 is less than 60 millimeters of mercury. Going back to the causes of hypoxemia that I have mentioned you before, the commonest cause of hypoxemia in type 1 respiratory failure is VQ mismatch, or ventilation perfusion mismatch. So what is VQ mismatch? So it is VQ mismatch is a mismatch between ventilation and perfusion that happens in the lung. So in simple words, what happens is blood moves through the pulmonary capillaries without picking up enough oxygen from the alveoli. So there's something inside the alveoli which impairs the normal oxygen diffusion to the capillaries, or something, an alveolar filling or an airspace filling, which impairs this process. So or the differential diagnosis for, the causes for this airway, so this air space or alveolar filling, you can, the things that can fill up these alveoli, the common things are blood, pus, or water. So blood like in the case of diffuse alveolar hemorrhage, for numerous causes like vasculitis, coagulation defects due to drugs, infections, pus, commonly due to pneumonia, can be the viral, bacterial, or fungal, or can be due to acute respiratory distress syndrome. Water represents cardiogenic pulmonary edema and other forms of acute respiratory distress. Less common causes include that can fill these alveoli, cells like eosinophils, lymphocytes, or cancer. Then protein, like in the case of pulmonary alveolar proteinosis, fat or lipid, like in lipoid pneumonia. And also pulmonary embolism, where the problem is in perfusion, the ventilation is intact, perfusion is deficient, will result in a VQ mismatch and results in hypoxia. So hypoxemic or type 1 respiratory failure is best treated with oxygen through nasal cannulae, non-rebreather mask or heated high flow nasal oxygen or invasive mechanical ventilation. Moving on to type 2 or hypercapnic respiratory failure, which is defined as PaCO2 of over 45 plus accompanying respiratory acidosis, applying the cardinal causes of hypoxemia, which I have told you before. The commonest cause of hypercapnic respiratory failure is hypoventilation or reduced minute ventilation. So we know that minute ventilation is derived by tidal volume multiplied by respiratory rate. So if either your tidal volume or respiratory rate goes down, the minute ventilation go down. So it is the ventilation that regulates the amount of carbon dioxide in our system, in our blood rather. So if the ventilation go down, invariably the carbon dioxide will go up, which results in increased PaCO2 and your pH will decrease. So this schematic diagram which I have made explains the causes for hypercapnic respiratory failure. A simple way of doing this is you can have, your patients you can classify them as those who won't breathe, can't breathe, or can't breathe enough. Won't breathe represents the central nervous system causes of hypercapnic respiratory failure, whereas can't breathe represents the neuromuscular causes of type 2 failure, and can't breathe enough represents your pulmonary causes. Talking about the central nervous system causes, won't breathe is due to central nervous system suppression, suppression of respiratory drive. The mechanism is again decreased respiratory rate, and examples are sedative or narcotic overdose. Can't breathe represents the neuromuscular or the diaphragmatic causes, causing neuromuscular or diaphragmatic dysfunction. Mechanism is insufficient tidal volume here. And examples are Guillain-Barré syndrome, myasthenia gravis, polio, botulism, or motor neuron diseases. Can't breathe enough represents your pulmonary causes, and the mechanism is overwhelmed respiratory mechanics. Common examples are COPD and asthma exacerbations. So having said that, we move on to the approach to hypoxia. So how would you approach a patient with hypoxia? First thing is patient stability. You have to stabilize your patient. In this case, you have to check for the general appearance. Your ABCs are very important: airway, breathing, and circulation. Then vital signs. So airway, look for stridor, to look for upper airway obstructions, especially like in children. Rhonchi can be due to lower airway obstructions. Important that you check whether the patient's breath sounds are heard bilaterally or the chest wall rise and fall equally, because you might be dealing with pneumothorax or a large pleural effusion. Is the patient tachycardic, which will tell you that there's an infection going on? Is the pulse steady? Because there can be an intravascular volume loss. And then you have to obtain a full set of vitals in stabilizing your patient, which will help to stabilize your patient. Quick history and physical exam is important. If your patient is stable enough, you can get a quick history, or you can get the history from a bystander. Quickly have a look at the previous patient clinic records, because that might tell you what's going on. There can be an underlying cardiac or a pulmonary cause, then you know that this time also you are dealing with something similar. History of smoking, recent surgeries will give a clue about an underlying pulmonary embolism. General appearance may give a clue to the underlying etiology. Cyanosis, remember, can be a sign of severe hypoxemia. Pale appearance may be due to blood loss in anemia. If you hear bilateral crackles on auscultation, can be due to heart failure. Focal or unilateral crackles will tell you that there probably be a lobar pneumonia. Absent breath sounds may point towards an effusion or a collapsed lung in the physical exam. Further evaluation, your saturation again, then arterial blood gas. PaO2 and PaCO2 levels, and importantly, the PO2 FiO2 ratio, the PF ratio, also important. Imaging wise, your chest x-rays will give a clue about again, tell you the underlying cause. Can be a large consolidation in case of a pneumonia, can be something like ARDS, hyperinflated lungs in case of a pulmonary, COPD, or CT chest and CT angiograms will important in finding an embolism. VQ scans are not frequently done, but may be important in case if you can't give iodinated contrast or patient is allergic to them, and in case of renal failures. Then the AA gradient is again important. AA gradient is the alveolar arterial oxygen gradient, the difference between the partial pressure, alveolar partial pressure of oxygen and the arterial partial pressure of oxygen. This gradient, if you can calculate, can narrow down your causes of hypoxia, which I will tell you in this slide. So as I've told you, AA gradient, capital A minus simple a, is the gradient of alveolar, is the difference between alveolar partial pressure of oxygen and arterial partial pressure of oxygen. The alveolar partial, arterial partial pressure of oxygen, you can get it from your blood gas. Alveolar partial pressure of oxygen, you get from the alveolar gas equation, which I haven't shown you here, which is a bit of a not so complex equation, which you can calculate from the alveolar gas equation, which contains your PaCO2 value as well. I think that slide which I have put here is missing here. So once you calculate this alveolar arterial gradient, if that gradient is normal, then the causes for hypoxia is low oxygen content in the alveoli. So the causes are, you can further narrow down your previous causes into low oxygen in there, like in low FiO2 in high altitude, hypoventilation, I mean, that is due to high PaCO2, of course, like in CNS depression, or like causes like obesity, hypoventilation, or obstructed airways, like, for example, in COPD. If the AA gradient is high, the cause is either a diffusion defect or a ventilation perfusion mismatch, or a shunt. So this is what I have told you before. How you calculate the AA gradient. Right. So other clues, I mean, other tools that you can use in evaluating an acutely hypoxic patient. This is a new or not so new tool which has come, the bedside lung ultrasound, which I want to talk about a few words on this. We had a very very informative lecture yesterday by Dr. Baker from Australia on lung ultrasound. So bedside lung ultrasound in emergency, or what we call blue protocol, is something which is very important in evaluating an acutely hypoxic patient in the acute setting. So this was first described by this gentleman called Professor Daniel Lichtenstein, a French intensivist. So it is the gold standard of immediate diagnosis of respiratory failure now, and so this relies on standard thoracic locations, what we call blue points, which I'll show you in a moment, and about 10 ultrasound profiles. So these are the standard blue points, which we call the blue points. There are 4 anterior blue points, right and left, upper and lower anterior blue points, and the posterolateral either side blue point called the PLAPS point. So altogether there are 6 blue points for a quick evaluation of what's going on in the chest. So this is like a fast scan in the acute abdomen, which we do. So this is the blue protocol. And there are, as I've told you before, some ultrasound profiles which people have described. So if they are there, you quickly know what is going on in our patient. There are ultrasound machines now in most of the respiratory units. So I think it's very important that we know about this that we can quickly evaluate an acute patient to find an underlying cause. First, you have to know what is the normal lung. Don't know whether this will play. Yeah. So normally what you should look is the normal lung surface that I mean, it will show what we call the bat sign or the lung sliding. So important thing is lung sliding. You have to look for the sliding of the visceral and parietal pleuras, which will I think it's not playing. So the visceral and the parietal pleura will slide on each other, on each other, and if that is there, then you know that the lung sliding is present, and then that is normal. So this is lung sliding. So important thing is to look for the absence of lung sliding. So absence of lung sliding will tell you that there's something wrong. So if the lung sliding is absent, then there are other profiles. For example, like in pneumothorax, the sign is called the lung point or the stratosphere sign. Here, this video will, I think we had few good videos yesterday by Dr. Baker on this in the lung ultrasound lecture that she delivered. So you can see there's a static pleural line in the left, and in the right side there's a moving the pleural line going coming from the right side of the screen. So this is what we call the stratosphere sign or the lung point sign. In interstitial syndrome, because we do get a lot of patients with interstitial pneumonias, ILDs, who comes with acute interstitial pneumonias. Again, the profile, ultrasonic profile is called the lung rockets. These are the B lines, which again, Dr. Baker yesterday explained them very well, the vertical B lines. You have to, if this picture is there, you have to think of lung rockets, which will tell you that there's an interstitial syndrome going on. Lung consolidation will give a sign called the fractal or the tissue-like sign, and pleural effusion will give you a sign called the cot or the sinusoid sign. So there are about 10 profiles like these, so be familiar with them because they are important in the acute setting for you to evaluate your patient to look for an underlying cause, a bedside evaluation. So we'll go back to the two cases that I've shown you in the beginning, to finish my lecture. The 82-year-old man who was a heavy smoker, had severe COPD, came with increased sputum production, cough, and worsening dyspnea. There were a lot of audible wheezes and rhonchi auscultation. Vital signs include high temperature and high blood pressure. He was tachycardic, tachypneic, and SATs dropped to 86 on room air. He was started on nebulized salbutamol and prednisolone. My question was, what is the best oxygen delivery method for this patient? Yes, the answer is obvious. You should give oxygen, graded oxygen through a Venturi mask. So why is that? Because we know in COPD, in severe COPD especially, there are areas in our lung which are less ventilated because of the bronchospasms and emphysema. So what will happen is, in these lungs, the hypoventilated areas are less perfused. If you remember your physiology, this mechanism is called the hypoxic pulmonary vasoconstriction. I mean, the less ventilated areas are less perfused. So what happens is, if you go and give high FiO2, high-grade oxygen to these patients, this hypoxic pulmonary vasoconstriction will get impaired or it's counteracted, and will result in increased physiologic dead space, which will worsen the VQ mismatch, and this results in oxygen-induced hypercapnia, something we already know. These things we already know. So therefore, it's important that you give graded oxygen to these patients, which you can achieve by using a Venturi mask. The second case, the 50-year-old man who sustained a gunshot injury, came to the ER. He had a lot of comorbidities along with COPD. He underwent an exploratory laparotomy, during which he receives 5 liters of normal saline. Upon extubation, he again went into respiratory distress. He was tachycardic. Auscultation reveals bibasal crackles. ABG, he was hypoxic, pH of 7.47, PSO2 was 36, bicarb of 21. Importantly, after giving 100% of oxygen, his ABG did not improve. So my question was, what was the underlying cause for the respiratory distress? The options which I have given you at the beginning, the answer is pulmonary edema. So why this patient was hypoxemic? If you this is about this AA gradient. If you calculate the AA gradient in this patient, remember he had low PCO2 levels, and he had elevated AA gradient here, which I haven't given you the calculation here, of course. So elevated AA gradient leaves only shunting and VQ mismatch as the potential causes. So a failure to improve his PaO2 or his ABG with after giving 100% oxygen makes VQ mismatch less possible. Therefore, it has to be a shunt, like pulmonary embolism. It has to be a shunt. And shunting would explain his hypoxemia. So the causes will be something like pulmonary edema, pneumonia, or a vascular shunt. This patient was given IV normal saline, and there were bibasal crackles on auscultation, so which tells you that it's probably cardiogenic pulmonary edema. With that, I will finish my talk, and thank you very much for listening.
Thank you, Dr. Rodrigo, for that very interesting lecture. So we'll keep the questions for the end of the session. Next lecture, so that will be another very practical and a very important topic: de-escalation from ventilation, an individualized approach. The lecture will be it will be conducted by Dr. Chandana Karunaratna, consultant anesthetist, who's working at District General Hospital, Ambalipitia. Over to you, sir.
Good morning, everyone. Thanks for the introduction. Now, my topic is de-escalation from ventilator. Now, for most mechanically ventilated patients, de-escalation or weaning and extubation is fairly rapid and uneventful process. However, there is a substantial proportion of patients, roughly about 30%, where weaning is difficult and likely to fail. So this poses a great challenge on the clinicians because the pathophysiology of weaning failure is quite complex and often multifactorial. So ventilator de-escalation is a vast and complex subject, and I don't think it can be sufficiently covered in a short lecture like this. So I would rather focus on some practically important common causes out of all the causes. Okay. Now, we all know that we breathe from the moment we are born to this world until the last breath we take just before we die. We don't pay particular attention to breathing as it is almost effortless in practical terms. So how is it possible? So we have a healthy respiratory system with central nervous system controlling our breathing process. In one hand, we have this muscle pump composed of mainly diaphragm and the intercostal muscles. This muscle pump has certain maximum capacity of work of breathing. Now, on the other hand, we have some load on the respiratory muscles, which is fortunately small enough, the resistance and the compliance, so that we have a huge reserve for breathing and we can continue breathing until we die. Now, when we have a problem with weaning, we have a problem with this capacity and the load balance. So this could be, say, problems with resistance and compliance, or could be problems with the diaphragmatic dysfunctions, things like that. Now, we all know that before we even attempt weaning, we have to make sure that the primary indication is sorted out, and then patient has got stable, otherwise stable clinical condition, normal oxygenation, ventilation, before we attempt, or acceptable level of oxygenation, ventilation before we attempt weaning or de-escalation. Now, causes of weaning failure can be categorized into these broad topics. For example, under high resistance, you can have tracheal stenosis, tracheomalacia, things like that. Under low compliance, you can have pulmonary edema, ARDS, things like that. And then cardiac dysfunction, diaphragmatic dysfunctions, things like that. So there are so many causes, which I'm not going to go through one by one. But if you want to learn a structured guideline-guided approach, there is a nice article which describes what is called ABC approach. It has got 5 domains. So this is the article which was published in Critical Care Journal some time back. the ABC of weaning failure. We don't have sufficient time to go through all this in detail. So instead, we will look into practical aspects of some important common causes of weaning failure and how to handle them. So there is one important cause or important issue we often overlook even in the textbooks and the guideline, but it's so common, sometimes we don't acknowledge this one. So usually during the acute phase of intubated patients, for example, patient with respiratory failure like ARDS, pulmonary edema, we sedate them heavily during the initial period to take control of the ventilation using, for example, SIME, volume control, things like that. So that's fair enough. But the only thing, if you look at the ICU chart, some of these patients, we have been giving too much sedatives. For example, say morphine 5 milligram per hour. Sorry, midazolam 5 milligram per hour. It's like midazolam 5 milligram per hour is about 120 milligram of midazolam per day. Imagine we give it for about 4 or 5 days. And then, so we are talking about patients, critically ill patients with multi-organ failure, renal failure. So these patients, they don't have enough capacity to metabolize all these medication. So even if you stop the medication completely, so they take longer to reach the awake-oriented state. So until such time, these patients will be disoriented. They behave like drunk individuals, and they won't tolerate the changes, sudden changes of weaning. So that is one big problem which we often overlook. So the other thing is when the patient is actually paralyzed and sedated, so they don't have any ventilator-patient interaction. So the ventilator will smoothly function, and there will be no asynchrony whatsoever. But when the transition happens from the sedated to spontaneous breathing, this actually happens gradually, and we often overlook this period, and then we continue to use the same SIVME settings, same ventilator settings. But the profiles, when you look at the spontaneous breathing, they need a different flow profile. They need different timings. The patient will not know what the ventilator is trying to do, and they will try to breathe on their own. And on top of this, patients are disoriented, sedated, so they will not properly. This is one of the common reasons why we fail weaning, but it's not really recognized and described in literature. So it is very important to make sure that you set the ventilator to the spontaneous breaths once they start spontaneous breathing. But the problem is a lot of people do not know. I mean, I have described certain ways of doing this one, but the only thing, you take some practice before you attempt these things. So you need to have a lot of experience in using ventilator and setting the breath to the spontaneous, setting the ventilator settings to the spontaneous breaths. So you have some kind of practice. For example, if you have no idea how to do this, you can actually, I'll tell you a different method to do that. But unfortunately, so these patients will be struggling on the ventilator because of the wrong settings and over-sedated state. Some of these patients actually, so we will have to resedate again once you start weaning because they are struggling. Sometimes I have seen some people tie these patients to the bed railing to prevent this patient struggling. But fortunately, some of these patients, they pull their tube out and then they live happily ever after. Now the thing is, still we do not realize that we have applied some wrong ventilator settings, and we still continue to do the same thing for the next patient. So okay. So these are actually I want to show you. Say, for example, if you have SIME volume control and you do not set the inspiratory time properly when the patient starts breathing. Now, for example, this is a flow profile of spontaneous breath. Usually, they require about 35-45 liters per minute peak flow rate. But if you look at the ventilator volume control mandatory breath flow waveform, it's like this. So they are giving only. So when the patient tries to breathe, there is flow starvation happening, and then so they are timing also. So the patients, if say you can actually settle this one by using pressure control and pressure support. But the only thing, even if you use pressure support, pressure control, you do not know, most people do not know how to set the pressure support adequately and the pressure control adequately. So you might give over assist or under assist and patient will still struggle. So these are the kind of problems we encounter. Now what can we do? So we can talk about using less sedation intervals, using sedation scores, to keep the patient sedation at a particular level so that patient is not too over-sedated but still conscious enough. But the problem is now here we have a patient who is already sedated and already too much sedated and disoriented and struggling. So as I told you, a lot of people find, a lot of clinicians even find it difficult to set the parameters to the patient's breathing pattern, and we end up over-sedating. So what we can do is, if you don't know how to do this, the settings of, so what we can do is we can actually stop all the sedatives and start some propofol infusion, because that's a short-acting one. It has got short context-sensitive half-time, meaning that even if you run a prolonged infusion of propofol, once you stop the propofol, then you can actually, the patient will wake up much more awake and oriented. You can give some, you give a chance for the body to metabolize the long-acting stuff, and then you can stop propofol, and the patient will be awake and oriented. You can actually quickly extubate if the patient is otherwise okay before something happens. If you keep the patient spontaneous, without knowing how to set the patient's breathing pattern to the ventilator. Now that is one important thing. The other one is the diaphragm dysfunction, which is diaphragm weakness is actually highly prevalent in critical ill patients, and this is consistently associated with poor outcomes, including ICU mortality and the prolonged weaning. And this diaphragm dysfunction may even exist prior to ICU admission. That may be one of the reasons why we mechanically ventilate these patients and intubate and ventilate, and it can also develop during the ICU stay. And there are so many reasons. Maybe it's because of sepsis and SIRS, maybe because of the steroids and neuromuscular blockers we use, or diaphragm ventilator-induced diaphragm dysfunction, ICU-acquired weakness, things like that. So many reasons for diaphragm dysfunction, which is very, very important, and it's very, very common in ICU patient. Now, I'm not going to go through a detailed scenario, but if you look at this scenario, which has, we have a 60-year-old patient who was subjected to prolonged ventilation due to sepsis and pneumonia. Now, if you look at these kind of patients, they are highly likely to have a diaphragmatic dysfunction. But the problem is, how can we identify this in our clinical setup? We can learn a lot of theory, but how can we identify? Now, to monitor diaphragm function, the gold standard is to look at the transdiaphragmatic pressure using some magnetic stimulation of the splenic nerves, which we don't practice in our clinical practice a lot. And then some people can use NAVA, which uses diaphragm electrical activity, using a dedicated nasogastric tube with EMG electrode. But only thing that need a specially dedicated ventilator, which we do not have. But what we have in our ICU is we have ultrasound scan lying around in most of the ICUs. So we can use, as previously described, ultrasound is quite useful. We can use diaphragm, we can actually assess the diaphragm function using the ultrasound. Basically, there are two main things we can do in addition to the lung ultrasound score: the diaphragm excursion, which is the movement of diaphragm, and the diaphragm thickening factor. So, so this is actually a very quick and easy non-invasive bedside method of looking at the diaphragm. So what you do is you take the say mid clavicular line and try to see a window and look at the diaphragm, and you can use the M mode, which you look at the changes along the time, and you can see the excursions happening in the diaphragm. So if the excursions are small, that means diaphragm is not having adequate power. So if you have less than 30 millimeter excursion, that suggests some kind of diaphragmatic dysfunction. And this has got a sensitivity of 83% and a specificity of 41%. Not very specific, but it's quite sensitive enough. And so if the patient is not having enough muscle power, you can see the diaphragm is almost barely moving, and it's less than 13 millimeters. So once you have some ability to use the ultrasound scan, you can actually bedside quickly, non-invasively check this diaphragm function. There is another much more sensitive and specific ultrasound way of checking that one is the diaphragm thickening fraction. What you do is you use a high frequency probe and try to see this zone of approximation, what we call it, the thorax and the diaphragm. So when they are at that place, you can see the peritoneum at the bottom, and the white one is the pleura, and you can see the diaphragm with a thin thin white line in between. So that's the diaphragm. So during breathing, you can check the using the M mode, you can check the thickening fraction of the diaphragm. So you can look at the end expiratory diaphragm thickness, and after the inspiration, you can check how much, what is the change, and change divided by the expiratory value, the small value, you can get the fraction multiplied by 100. So this is fairly sensitive, 88% sensitivity, and much more specific compared to diaphragm dysfunction. So these are doable and can be used practically at your bedside. Once you start using ultrasound scan, these are quite handy when you want to, before you extubate the patient, before you try to, in a problematic patient, not each and every patient, you can assess the diaphragm function before you, so you can avoid a lot of failures by doing these things. Now, we generally think the limb muscle weakness there is some association with the diaphragm weakness. Most of the time it is true, but it's not always. You can have a diaphragm weakness in the presence of normal limb muscles, and you can have sufficient diaphragm power in the presence of limb weakness also. So, ultrasound is quite useful in assessing these situations. Now, do we have any treatment for diaphragm dysfunction? No, not available at the moment. But any vasoconstrictor drugs like noradrenaline, high doses of alpha blockers, when they vasoconstrict, you get low blood supply to the diaphragm, and there is a possibility that the diaphragm dysfunction could be due to one of these reasons. So you can, the levosimendan, it has a vasodilator properties, inotrope, so it will improve blood flow to the diaphragm, but it's not clinically proven, statistically proven beneficial. And then there are side effects, like you can even use dopamine. Dopamine also causes dilatation of the diaphragm blood vessels, but the only thing, it can cause some arrhythmia, so it's not really recommended unless there is no other option. So the other reason is the weaning-induced pulmonary edema. This is actually increasingly being recognized as one of the most common causes of weaning failure. In fact, certain recent articles said about more than 1/3 of patients they experience some amount of pulmonary edema during this because of certain reasons. So basically, this happens in patients who has got diagnosed or undiagnosed some kind of myocardial dysfunction, but even in patients with no significant myocardial problem. So you may see this, especially when acute illness, we give a lot of fluids to the patients, and these fluid, generally body tries to get rid of these fluid by having high urine outputs, but sometimes these people cannot pass enough fluid, so they are fluid overloaded. So once you transition from the mechanical ventilator to spontaneous, there are a lot of changes of volume and cardiac function happening. So if you look at this thing, you can see I've got the pink one on the sedated paralyzed state and the green one in the spontaneous state. You can see the intrathoracic pressure is positive when you give positive pressure ventilation, the ventilation, and then you have low venous return because of low venous return, the intrathoracic pressure, and your preload, left and right preload is low, and then your worker breathing is almost negligible because you are controlling, your ventilator is giving the breath, and the catecholamine in the circulation is actually at a low level. But once you suddenly transition from that one to spontaneous breathing, now you have a negative intrathoracic pressure. Now your venous return improves. Now your preload, so everything will increase. So whether the cardiac function is ready enough or they are strong enough to accommodate or tolerate these changes is quite important. So especially when you have a patient with some kind of marginal cardiac dysfunction and on top of you have fluid overload, this is possible. So that the patient will tip the balance. So he'll be quite okay on the ventilator, but the moment you try to wean, they will develop. So now the thing is, you can talk about all these theories. How can we detect this? Quite important to detect this early. Late detection will have a lot of complications. So if you detect early, you can just give some furosemide, get rid of all the fluid, or do something for the cardiac dysfunction, or do something. So now, how do you detect? It's not that easy, although we discussed, because the features will be similar to non-cardiac ones also. So you have to have high degree of suspicion. Basically, it's quite common in COPD patient. That's what the literature says. So you can do an ECG, you can do thoracic echoes, you can do lung ultrasound scores, and biomarkers like BNP, which has got certain sensitivity, and extravascular lung water rise. If you know how to do it, like certain cardiac output monitoring, that's highly specific. So I'll just. So is there any quick way to detect at bedside? So we can once again use ultrasound, but if you know how to get a basic 4-chamber wave of the heart, and if your ultrasound scan happen to have pulse wave Doppler, then you can use the cursor and get that window up to the end of the, you can look at the mitral valve flow. This is not actually rocket science. When you place the probe, if there is a flow happening towards the probe, you have a positive reflection. So the left ventricle, you get blood flow. The bulk of the blood flow happens during diastole, in the early diastole part. So you have a larger peak. So that's called E wave. And during atrial contraction, you have a smaller peak because that contributes to a small amount. So you have A wave there. So basically the E wave is larger, A wave is smaller. But if it happens other way around, that means there is diastolic dysfunction. This is actually much more common than systolic dysfunction in weaning failure. So it's quite important to look at this diastolic dysfunction. So if you don't have to know in great detail, but you can place the probe and you do this one. And there are certain wave patterns in diastolic dysfunction. You can actually optimize the wave during using certain maneuvers. But whatever it is, you get the idea. And so what can we do? So you have to evaluate for existing cardiac dysfunction and look for features of fluid overload and optimize fluid balance by removing some fluid if it is needed. I usually do stop giving fluids rather than giving furosemide, but you can try furosemide if it is, and if you know that there is a lot of fluid overload and you are planning for early extubation. But I generally stop fluid altogether so that the body can handle the fluid status. But it's possible to give furosemide boluses, and you can discuss with the cardiology people and start some AC inhibitors, beta blockers, depending on their advice. So you can reassess. Once you start the spontaneous breathing trial, you can reassess and continue. And when you want to extubate, so you can basically do TPs trials. You can do spontaneous breathing with the pressure support CPAP, but what we generally do, we don't usually use TPs, but in this particular instance, TPs is much better because even if you apply a pressure support of, say, PEEP of 5 or CPAP of 5 with the spontaneous breathing trial, these patients will improve their cardiac function so that the moment you extubate, now they go back to the different state and they will have cardiac failure once again. So in this particular, I don't usually use TPs trials, but you should actually try TPs rather than normal CPAP pressure support trial because that will simulate much more natural conditions so that you can avoid some of these failures. My time is up. I have another one COPD. I'll just try to quickly go through. So COPD, we have the biggest problem is intrinsic PEEP because they find it, COPD patients they can breathe with difficulty, breathe in, but exhalation is much more difficult. So they have accumulation of air inside their lungs, intrinsic PEEP. So the lung comes to a very unfavorable position in the pressure volume curve. So they have increased work of breathing and they have a positive pressure inside the lung. And when they are connected to the ventilator, they have a problem of triggering the ventilator because ventilator has got no idea what the pressure inside the lung, and the patient has to overcome the intrinsic pressure. For example, if you have set a trigger of -2, generally if the PEEP is 5, the patient has to drop the pressure to 3, then the ventilator will trigger. But here in these patients, if you have an intrinsic PEEP of 12 and the trigger of 2, so patient has to first overcome the 12 and then another 2. So it's about setting a trigger of 14, -4. It's very difficult for this patient. So it's sometimes, so what you have to do is to improve the airway by giving bronchodilators, anti-inflammatories, infection control and everything. But still these are not, in real life when you try to do, it's not really possible and they are kind of end stage. So sometimes to help patient extubate, you can apply some positive pressure outside like external PEEP. That's also dangerous having a lot of pressure, but there are ways of doing that. Anyway, you can slightly increase the PEEP so that your baseline pressure is high. So that when so you don't have to drop down to 3, now you can drop down to a baseline pressure. That is one thing. There are so many other things to do with the COPD. Because of the time limitation, I wouldn't have enough time to go through. And one important thing, I think you heard in the morning, setting the exhalation sensitivity from 25 to higher value, because these people, they try to take a breath, but the ventilator, because of the way it is designed to function in the spontaneous breathing, So spontaneous breathing, the ventilator wait until the flow drops to 25%. But in these people, they don't want a prolonged breath, but they take a breath, but the ventilator will not open the exhalation valve until the flow drops to 25%. So you can drop it not 25, you can make it say 50% or to 45% so that the ventilator will open the valve early enough so that they can exhale. They have enough exhalation time. So that's about the individual approach about weaning. So if you want to ask any question, you can ask at the end of the presentation. Thank you.
Thank you very much, Dr. Chandana, and you have actually elaborated few important hidden aspects of weaning failure. So very interesting. Thank you very much. So next one is pneumonia in the critically ill patient, choosing the right antibiotic. Professor Ignacio Martin is from Ireland. He's a clinical professor in clinical medicine, Trinity College, Dublin, Ireland, and he's also a consultant in intensive care medicine, St. James Hospital. So it's going to be a recorded video.
Hi, everyone. Good morning, good afternoon, good evening. My name is Ignacio Martin Loeches. I am a professor of critical care in Trinity College in Ireland, and I am a full-time consultant in intensive care medicine in St. James's Hospital. And I feel honored to have the opportunity to give this lecture to the annual academic session of the pulmonologists of Sri Lanka, that with the title Pneumonia in the Critical Ill Patient, Choosing the Right Antibiotic. These are my conflicts of interest for the last year in terms of industry and academia. And with no delay, we are going to start talking about this interesting topic and taking into account two major guidelines, the American guidelines and the European guidelines, that they are more than European, global, because we have different societies, including also Latin American societies. Probably the first thing that we have to say is that when we are going to initiate antimicrobial therapy, the first is following guidelines is a good thing, because then we are going to implement appropriate antibiotic treatment. This is an old study showing something not very surprising. You put guidelines in place, you are going to increase the appropriate antibiotic treatment. However, the important thing about this is that in 2011, we have this paper showing that in 4 major teaching hospitals in the US, following guidelines were associated with higher mortality. And I think that one of the problems with guidelines is that they are making things more and more simple. And that is obviously helping to do things, but on the other side, we are missing some points. Let's look at why this guideline compliant had higher mortality. Probably because these compliant patients, they were sicker. So, and this is something that it is very important to consider when we are looking at how we are going to treat a patient. And also these guidelines, they did not account for some particular things, such as the escalation, dosing, and timing of treatment in antibiotics. Interestingly, after this paper was published, there was a very nice editorial from Greece that could represent many of the clinical practice in different countries, probably also in some units in Sri Lanka, saying that, well, we have a high prevalence of multi-drug resistant pathogens. So that means that if we follow guidelines, we are not going to give the right antibiotics. And I think that we all, when we are talking about ventilator-associated pneumonia, we have considered this definition of early onset, late onset. Early onset means that you are going to have less pathogenic or less resistant pathogens, and late onset, more resistant pathogens. And this is not true, because you can see in this paper from Italy that is not a good definition. Then we need to consider that guidelines are going to give us a taste, but they are not going to give us the whole truth. And this is a reason that we need to incorporate something that is called ecology. And ecology is local epidemiology. This is a concept that was brought to us many years ago, more than 20 years ago, showing that in different units, this is a paper from Jordi Rello, showing that in different units, you are going to have a different epidemiology. More recently, we published this paper that we were showing that depending on the country that you practice in Europe, you are going to have a different prevalence. So this is something that is going to provide a good insight. But also, if you are working in a big major teaching hospital and you have different ICUs, you are going to have obviously different ecology depending on the ICU and the patient. Then the question is, well, we have a problem, let's find the solution. And the solution is that we need to maybe incorporate not only the common risk factors, but also a new array of risk factors. And these are probably the local epidemiology and the severity of the patient. And this is something that we showed 10 years ago with this major paper that found that in patients that they were in group one means patients that they did not have any resistance, we had at the level of those that they had identifiable risk factors. So as you can see, patients, they were having hidden risk factors. And which are these hidden risk factors of multi-drug resistant pathogens? First is severity. We have seen patients that they are developing septic shock. They are going to have a higher prevalence of multi-drug resistant pathogens. And the second is prevalence in the unit. So if you are in a unit with high prevalence of resistant, it's likely that you are going to develop a resistant pathogen. Another important matter when we are looking for the treatment is that there are some other entities. We are been talking a lot about ventilator-associated pneumonia, but there is an entity that has been there forever, but we are giving more attention, that is called hospital-acquired pneumonia. So patients that they are developing a pneumonia on the ward, and they need to be mechanically ventilated. So this is the reason that when we see in different trials, those patients that they have HAP ventilated, so patients from the ward that they need to come to the ICU and to be ventilated, they have a much higher mortality. So that creates a paradigm shift in order to consider if these patients are going to have a worse entity. And I do believe that they do, but also I think that we need to grade the disease. And I think that here, this is a paper published a couple of years ago showing that we have a grading of the disease from the ward to the ICU. And also in ICU, a part of the non-ventilated ICU acquired pneumonia, we have another entity that are those patients that they are in ICU after a major procedure, for instance, that they are not ventilated, but they are not getting better, and they eventually develop a pneumonia when they are in ICU, and they need to get this mechanical ventilation, and then the mortality could go up to 50%. So what about treatments? I think that first we need to hit hard. We need obviously to get a diagnosis for what we are doing. And then at day 3 to 5 is when we are going to be in the need to start to focus and to try to find a three-way approach. And this is the 3Ds that I mentioned in this paper, that is a review paper that we publish in intensive care medicine. The first is dosing. Probably more important than the MIC is the MPC, that is the mutant potential concentration. So we need to hit hard in order to decrease the number of strains that they are going to be either resistant or potentially resistant. Also, we have a current problem that is the renal clearance. In some particular patients, we have a elevated or augmented renal clearance. This is common in patients that they are less sick, patients that they are with less age and with a low severity of a score. And this is something that we have seen in major clinical trials. This is a recent clinical trial that is ceftolozane and tazobactam against meropenem. And you can see that up to 20%, almost 20% of the patients, they had a very high creatinine clearance. Also, it's important when we are talking in dosing that the drug is going to reach the right component. So because this is what we learn in the med school, peripheral component, central component, but the lung is an important organ, because if that drug is not going to reach the lung tissue, is not going to make. And I think that this is especially relevant with some drugs, such as aminoglycosides, that they are going to work very well in the lab, they are going to work very well in the central component, but they are not going to penetrate into the lung. Then this is the reason that we can see that we have some studies that they are going to put more emphasis in getting this amount of adequate drug concentration. This is again the ASPECT trial showing that before doing the design of the study, we needed to be sure that we were reaching adequate lung concentrations with ceftolozane and tazobactam. Similarly, it was done by David Nicolau in the States with ceftazidime avibactam. And I think that these phase 1 studies in healthy volunteers are really giving a good understanding of the type of a dose that we are going to provide in big trials, because it's going to be the only way that we are going to decrease a treatment failure, or at least we are going to see drugs that they are going to reach adequately the lung, or at least with the right dose. The second is about duration. And I think that duration needs to be short, needs to start sharp and needs to stop sharp. And this is a reason that we can see these two scenarios, that if we are starting the drug on day 3 and they prolong the treatment for 3 weeks, the number of resistance is going to increase compared to a short course of antibiotics. This is not new. We have seen this study from Jan Chastre, published in JAMA, very relevant. There is a new study that is not in this slide, but was published recently in ICM with a group of Marleon, that we can see that a short course of antibiotic is not going to be associated to a higher mortality. We can count on different tools, and this is the example that we can use biomarkers such as procalcitonin, not as a marker of infection, but as a marker of reducing antibiotic consumption. And then the third D is something that we have to implement, that is de-escalation. Definitely de-escalation is going to be associated to a better outcome, probably because we have given the right antibiotic and we have the opportunity to de-escalate, and also because we are going to have less collateral damage, less resistance, less problems when we are giving an antibiotic that is not appropriate to that patient. However, I think that it's important to consider that when we are talking about antibiotics, antibiotics needs to be appropriate, because it's the only thing that has shown and associated with increased mortality. I think that we need new drugs. This is the reason that in this old survey, the majority of the responders, they said, oh, we need more gram-negative agents. And also in different papers, and this is a paper that we published with Mike Niederman and Tony Torres, we showed that this is in the agenda of the research agenda in BAP and hospital-acquired pneumonia. Why we need new antibiotics? Because we have seen that in the world, the resistance is coming up. And this is interesting because when we are looking at recent papers, this is the century. The century is like a snapshot of the different resistance in different years. We have seen an increase in multi-drug resistant pathogens. Even the threat of carbapenem-resistant Enterobacteriaceae that we have seen that is a big deal since 2000. Also, we are having more and more difficult to treat pathogens that they are going to be resistant to what we call first-line high efficient and efficacy low toxicity agents. And we have seen also that for some particular bugs, I'm just showing Enterobacteriaceae and Pseudomonas, we see that the number of resistance increase. We can even see that, for instance, in meropenem, that in many, many countries is a last resource of treatment, the resistance can be as high as, depending on different classifications, 10% using, in this case, EUCAST. So probably the most important is to avoid inappropriate antibiotic treatment to decrease resistance. Also, this is something that we have seen and we have learned over the last pandemic, where the number of infections has increased and the number of patients with multi-drug resistant Pseudomonas has also increased, as we can see in this graph. Well, I think that it's important to consider that we need to have a simple approach. I think that if the patient is very sick, patients that they have septic shock, the use of double or combo gram anti-pseudomonal coverage is mandatory. and using an MRSA treatment depending on the ecology. So we can give you only one recipe, but different recipes depending on the place that you are practicing. I think that when we are now going into which antibiotic I need to choose, I think that this study really changed everything, or at least it creates a huge amount of dilemma if we need to use one drug or another. This is for patients that they have ESBL, and we can see that patients that they were receiving piperacillin tazobactam for ceftriaxone resistant, the mortality was elevated compared to meropenem. So that prone to us to use more carbapenems, and that eventually made us to develop more resistance. And the resistance and the consequence is that we have developed more carbapenem-resistant Enterobacteriaceae and Pseudomonas. We can see that we have these three classes, A, B, and D. And then also in the different classes, I think that for A, the best example would be KPCs. For B, that is the meta-beta-lactamases, that they are mainly a big problem in India and in the southeast, probably in some areas in Sri Lanka. And the D are those that they have OXA, especially OXA 48, depending on the country. So, and this is the reason that we cannot give only one recommendation. I cannot give a huge amount of data depending on that. And I would refer to different papers. These are papers that they were published by my group, but I think that you have a good amount of new alternatives. In this particular paper, I am showing 6 new beta-lactams and 2 new other classes that they are showing a great understanding of the differences. And trying to make things a little bit better, or at least a little bit more simple, I think that we can consider these 3 major groups: carbapenem-resistant Enterobacteriaceae, when I consider that probably the first choice would be the use of ceftazidime avibactam. For Pseudomonas aeruginosa, probably the first choice could be ceftolozane tazobactam. And for carbapenem-resistant Acinetobacter, probably the first choice could be ceftriaxone. However, things are not that simple. So this is definitely for empirical treatment, but we also have an emergence of some particular strain. We have given a lot of scope to maybe meta-beta-lactamases. As you can see in this graph, we have also some particular issues with KPCs. And this is the reason that when we go to Klebsiella pneumonia, we can see that probably we need to go to if there is an OXA 48 or not. And then when it's an OXA 48, you see that the alternative here, in case that ceftazidime avibactam is susceptible, that could be a good choice. In case that is not OXA 48, and then we can exclude meta-beta-lactamases, you need to evaluate is the KPC type. And in this case, you are going to have 2 alternatives. In this case, imipenem rolabactam or meropenem barbabactam. And definitely, if you have meta-beta-lactamases, in case of metallo-beta-lactamases, you have little options. You have maybe atrionam avibactam and probably ceftriaxone. So I think that just for this lecture, I wanted to really you to focus on the different alternatives, just as a way to go back on the papers and to go back on the literature in order to see how important it is to learn in microbiology to adequately treat patients. So, and I would like to finish with something that is more general, but I think that remember that if you have to escalate, it means that you haven't given appropriate antibiotic treatment. So that means that you are going to go towards higher mortality. And this particular mantra that we have all consider, when the patient is very, very sick, the patient is in septic shock, we have to give all the antibiotics, but maybe the patient is not that shocked, we might need to wait. I think that this is partially true, and this is maybe food for thought. As you can see in this paper, patients that they were getting worse in terms of cardiovascular status, so that they are really more shocked, that they need more vasopressors. The effect of appropriate antibiotic treatment was getting less strong in terms of mortality benefit when the patient was sicker. So I think that this is the reason that we should consider when we really have an infection, not to wait. And this is a type of, an algorithm that we need to consider, that is just something that I consider when I'm treating a patient, and is to see if the problem is coming from the community, from the hospital or the ICU, considering the guidelines that you have at a local level, and then considering probably the type of antimicrobials that we are using, the severity, the ecology, and trying to go to short duration of antibiotics to develop less resistance. And this is going to help us with clinical progression, with biomarkers in case of low MICs and not MDR settings, and then to implement the escalation. So just the summary is considering that MDR is an important concept, the ecology is important. Patients with HAP that they need to be ventilated, they have a high severity. Remember the 3Ds, dosing, duration, and de-escalation. Concerns with GMVs, especially Pseudomonas, and escalation means a bad choice. And with this, I would like to say thank you very much for your attention, and I hope that you have a lovely day.
We would like to thank Professor Martin Loches for that very timely topic. Now, the next topic would be done by Professor Antoni Torres from Spain. He's a professor in medicine at University of Barcelona and head of the respiratory intensive care unit at University of Barcelona. He'll be talking about ventilator-associated pneumonia, old foes and new challenges.
Hello to everyone. My name is Antoni Torres. I am professor of pulmonology and critical care at University of Barcelona. I am pulmonologist and respiratory intensive care physician. Thank you very much for inviting me to this Sri Lanka annual College of Pulmonologists 2023 annual meeting. And my talk will be ventilator-associated pneumonia, all foes and new challenges. These are my disclosures. And let's start with the summary of the last guidelines, especially those published in 2016 and 17 by IDSA, ATS, and European Respiratory Society, plus other European societies and a lot, respectively. The guidelines for hospital-acquired pneumonia, ventilator-associated pneumonia. What has happened after that publication? Well, let's see some definitions, because now we recognize that there are other groups of hospital pneumonia acquired patients. Hospital-acquired pneumonia is a pneumonia that occurs 48 hours or more after admission, which was not incubating at the time of admission, not associated with mechanical ventilation. This is the overall definition. VAP, or ventilator-associated pneumonia, is pneumonia that arises more than 48 hours after mechanical ventilation, and ventilated HAP is that pneumonia that occurs 48 hours or more after admission, and which was not incubated at the time of admission, not associated at the beginning with mechanical ventilation, but that patients will require mechanical ventilation later on. And non-ventilated is those patients, the same group, but without need of mechanical ventilation. This is important because we realize, and others did as well, that the highest mortality is in the ventilated bacterial HAP, 30 to 40% compared to VAP, 20 to 30, and to HAP that did not require mechanical ventilation, the mortality is 15 to 20%. This has been confirmed in this study from Talbot, in which we included our clinical database, and you can see that this is what we observed. This is from Silverberg, and they confirmed this difference in mortalities. They look at the same groups, and ventilated HAP had the highest mortality. And this is probably because the late recognition of this disease if the patients are outside of the ICU. And what about the etiology? The etiology is probably more or less very similar compared to ventilator-associated pneumonia. This is a letter to the editor as regards a paper published in Intensive Care Medicine at etiology of hospital-acquired pneumonia non-ventilated. If you look at this, and when we corrected the results by the number of samples taken, Enterobacteriaceae, non-fermenting gram-negative bacilli, Staph aureus, methicillin-resistant or not, and Streptococcus pneumoniae in a very few proportion, where the main microorganism is very similar between the intubated and non-intubated patients. So that means that we have to treat these patients very similarly compared to VAP. Another problem now and after the guidelines is the increase in percentage and in numbers of the what is called the multidrug resistant pathogens. This is an overall classification that do not clarify the mechanism of resistance, but classifies the microorganism not MDR without resistance, MDR and XDR or PANDR according to the number of resistance to the families of antibiotics. And again, this is not giving us a sense about the mechanism of resistance. This is the typical, at least in the south of Europe, microbial etiology of ICU-acquired hospital pneumonia that includes VAP and ventilated HAP and HAP not ventilated. And this is clinical data, 2019, and you can see here that Staph aureus, 19%, MRSA and MRSA, Pseudomonas aeruginosa, and Enterobacteria are the main microorganisms. 25% of the cases were polymicrobial, 8% Acinetobacter, and this is not equal in all the units. It changes when you go to other units, to other patterns of resistance, etc. This is very important. So the main therapeutic principles in HAP and BAP is that MDR, XDR pathogens are associated with higher rates of initial inadequate antibiotic. This is important. Initial non-adequate antibiotic treatment is associated with higher mortality. Causative pathogens and their associated resistance profile are highly variable. And finally, that mortality of MDR, XDR, PDR, HAP has increased. These are the priority in red here. Microorganisms determined by the World Health Organization. This is from Taconelli, Lancet Infectious Disease. And the World Health Organization declared that Acinetobacter baumannii carbapenem resistant, Pseudomonas aeruginosa carbapenem resistant, Enterobacterales carbapenem resistant, and third generation cephalosporin resistant are the main important and critical microorganisms to be studied and to develop antibiotics against, developing diagnostics as well. And look at this about the importance in Enterobacterales of the mechanism of resistance. And this is a map of the world. You can see here, for example, in Europe and in the north of Africa, the OXA48 Klebsiella pneumoniae and Enterobacterales is the main mechanism. In Italy, the mechanism is KPC, while in India and in Pakistan, the problem is metallo-beta-lactamases, very difficult to treat, and in Australia, imipenemase. And then it is very important to know the epidemiology of the resistance. And the questions and considerations are the following. Do HAP, BAP, and ventilated HAP have the same microbial etiology? We refer, I mentioned this before. Second, how can we improve our microbiological prediction? Can rapid microbial tests help? Which algorithms and antibiotics do you have to use? Specific considerations. Let's go to the first. Now, in addition to the classical test that include stains like gram stain and cultures and other, now we have real-time PCR for particular microorganisms such as MRSA, MSSA, and a gene expert carbapenemase resistant, including this type of resistance, but this is for single microorganism. More interesting is in the market, the evidence and the availability of the multiplex PCR panels, particularly BioFire FilmArray and Curetis Univero low respiratory tract panel. You can see here the type of microorganisms that they detect and the mechanism of resistance. And I really think that these platforms that differ in the turnaround time and other issues is the are the future of the diagnostic because they offer in a very quick time a sensitive detection of microorganisms. The problem probably is the specificity. There are studies about that, about using these platforms that, in that case, they use it bronchoalveolar lavage in patients with pneumonia, CAP and HAP, and more sensitivity when using PCR techniques, even in patients having received antibiotics. The first study is a rapid detection of methicillin-resistant Staphylococcus aureus in BAL in patients with suspicion of MRSA infection and causing BAP, and they randomized to rapid detection trial versus usual of care. Sensitivity of the rapid detection trial for MRSA in BAL was 95. They had lower days of linezolid or vancomycin in the intervention arm, and the trial was stopped because the mortalities were different. This is important, was published in CHEST 2018. This is the INHALE study published in Thorax 2022, and in that study, they compare the performance of the different platforms that include several microorganisms resistant, that is Univero and FilmArray. And you have the full positive concordance, the full negative concordance, the partial concordance, the minor discordance, and the major discordance. And this is, for example, the detection reported at higher concentrations, full positive 20%, full negative 40%, partial concordance 11%, discordance minor in 15% of the cases, and the major discordance between the two platforms only in the 8% of cases. So now these platforms are available, especially the BioFire FilmArray Pneumonia Plus panel. What about treatment? Let's move to the treatment. Still, most of the antibiotic treatment is empirical. I hope that with implementation of these new tests, these platforms, this is going to change. And these are the recommendations for empirical treatment from the 2016 guidelines published in Clinical Infectious Disease, IDSA, ATS. For gram-positives, they still included vancomycin and linezolid. For gram-negative, anti-pseudomonas penicillins, pipertazobactam, cefepime, ceftazidime, carbapenems, imipenem, meropenem, and monobactam such as astrionam. And other families, fluoroquinolin, ciprofloxacin, or levofloxacin, or other families, aminoglycosides, amikacin, gentamicin, tobramycin, and polymyxins. Not very good antibiotics with bad penetration and difficult to control the levels. Well, we are lucky because we have new antibiotics for HAP and BAP. In the next slides, you will see the drug, the spectrum, the label indications by EMA and FDA, and the approved dosage. Ceftobiprole is not really a new one, and this is a non-extended spectrum beta-lactamase, non-MPC, and non-carbapenemase producing Enterobacterales pseudomonas aeruginosa MRSA. Is approved by EMA for BAP excluding HAP. The really new one are ceftazidime and abivac. You can see the mechanism here against the resistance, ceftolozane, tazobactam, and the label indications. In this case, ESBL, KPC, MC, and some OXA48, Enterobacterales and MDR pseudomonas. And here, ESBL producing Enterobacterales, MDR pseudomonas, and some anaerobes, Streptococcus and MSSA. Other antibiotics, not so frequently used now, are meropenem, bevobactam, imipenem, relebactam, and cefiderocol. The spectrum, again, is important to know the specific spectrum of each drug against resistance, because for that reason it's going to be very important to know the mechanism of resistance. And in the case of these, meropenem, bevobactam is against ESBL, KPC, AMC producing Enterobacterales, non-MDR pseudomonas, non-MDR Acinetobacter baumannii, Streptococcus spp, and MSSA. Imipenem relevactam silastatin, ESBL, KPC producing enterobacterales, MDR Pseudomonas aeruginosa, and MSSA. And finally, cefiderocol, ESBL, carbapenem resistant enterobacterales, classes A, B, and D, carbapenem resistant Pseudomonas, Strenotrophomonas maltophilia, Acinetobacter baumannii resistant to carbapenems. This is important because it's one of the few drugs that apparently is sensitive to against any mechanism of resistance. As regards Cephtalus antazobactam, this was studied in ventilated associated pneumonia and ventilated hospital-acquired pneumonia, compared with meropenem, with a primary endpoint of 28 days mortality. And the results demonstrated that for the overall population, there was non-inferiority, but there were differences in the subset of patients with ventilated hospital-acquired pneumonia and those with treatment failure. This is important. And this is the ceftazidime avibactam study in patients with HAP and BAP that compares ceftazidime avibactam at these dosages with meropenem, with the aim and the primary endpoint of non-inferiority, and with 12.5% margin. Results were similar for all populations and confirmed the non-inferiority of ceftazidime avibactam compared to meropenem. The RESTORE IMI2 was the imipenem relevactam study versus pipertazobactam in adults with HAP and BAP, and look at they compare imipenem silastatin relevactam with piperacillin-tazobactam. They could add linezolid. And the primary endpoint was 28-day all-cause mortality, and the results demonstrated that in the group of higher severity, the 28-day mortality was better, importantly, better for imipenem relevactam compared to pipertazobactam. Finally, I think it's the last, the APEX study, they compared cefiderocol versus meropenem 3-hour infusion in patients with HAP-BAP or healthcare-associated pneumonia. And they look at the 14-day mortality, 28-day in the clinical cure, and there were no difference comparing cefiderocol meropenem. Cefiderocol was non-inferior to meropenem. Finally, another point that is important because it was shown in the ASPECT study, the group of the treatment failure, we have to define what is non-response in VAP. Well, we use clinical signs and symptoms at 72, 96 hours after BAP diagnosis, a lack of improvement in PaO2, FiO2, persistence of fever or hypothermia with purulent respiratory secretions, increase in pulmonary infiltrates, new onset septic shock or multiple organ dysfunction syndrome, or an increase in the SOFA score. Other include CPIS, biomarkers, procalcitonin, that can be used for treatment failure, but this is not totally determined. The microbiological response is important. And you have to look at this article that we published in Seminars of Respiratory and Critical Care Medicine in 2022 that include which were the criteria. Causes of treatment failure. Well, the first and most important is inappropriate antibiotic treatment, and this is associated with higher mortality. But others that you have to think about is inadequate antibiotic concentration in the blood. This is very important. Think that the mechanical ventilated patients have different PK/PD behavior compared to non-ventilated patients. Importantly, you have to take a sample at day 3 or 4 and to see what happened, because sometimes new pathogens are isolated or the concentration of microorganisms is still very high. Please look at this article. We look at this and we call this prediction of ventilator-associated pneumonia outcomes according to the early microbiological response retrospective study. We have to think about comorbidities as a cause of treatment failure, and finally, antibiotic side effects that promote the change of antibiotics. So in conclusion, I think that after Happenbach guidelines, we have to be aware of these three different populations of hospital-acquired pneumonia, importantly including those patients with hospital-acquired pneumonia that started with spontaneous breathing but needed ventilation later on. These patients have the highest mortality. Now we have, or we can use molecular PCR platforms to rapidly detect microbes and their resistance, and this will radically change, in my opinion, the management of nosocomial pneumonia. We have new antibiotics with enhanced gram-negative activity mainly that have completely the management of these MDR, XDR gram-negative microorganisms, especially the Enterobacterales resistant to carbapenems, Pseudomonas multiresistance, and in part Acinetobacter carbapenem resistant. And finally, we have to follow up the treatment failure, which is frequent in nosocomial pneumonia and that must be evaluated clinically and microbiology. Thank you very much for your attention, and I am not able to attend in person this meeting, but you can send me by mail any question that you have. Again, thank you.
So that's the end of four presentations. Only thing we have overrun the time. If you have any burning question, we will give you another 2-3 minutes to ask questions from our speakers. Unfortunately, other two overseas speakers are not available. Anything related to hypoxemic respiratory failure and the weaning from the ventilator, the liberation? No questions. No questions, right. So thank you very much. Before we wind up the session, I think we have to present the certificate of appreciation for our speakers. Would you like to? Right, he'll be doing that, right.
Our first speaker, Dr. Damit Rodrigo. I would invite my co-chair, Dr. Haritha Dharmakirti, to present certificate to Dr. Rodrigo. And Dr. Chandana Karunaratna, there's a small token of appreciation as well as a certificate. We have a small token of appreciation for Dr. Haritha Dharmakirti for chairing these sessions and for his contributions. So thank you very much, and that concludes the session.